Hello, good evening. This is again Professor Nick. Today is March 26, about 9:45 p.m. Saturday. Uh, this is I'm in Brooklyn, New York, and we're gonna go over Hematology PA MP board review notes. They're 100% blueprints fit. And once again, if you need to contact me, please email me at nickm like Mary, D like dog, the number one at gmail.com. Let's go to slide number 2. The hematology system blueprint notes. Blueprint involve couple areas, but major are 3: anemias, number 1; number 2, coagulation disorders; and number 3, malignancies. Anemias has 9 types. We'll go one after another. Number 1, anemia of chronic disease. Number 2, aplastic anemia. Number 3, folic deficiency anemia. Number 4, G6PD deficiency anemia. Number 5, hemolytic anemia. Number 6, iron deficiency anemia. Number 7 is sickle cell anemia. Number 8, thalassemia. And the last one, number 9, vitamin B12 deficiency anemia. The second big group, this is the coagulation disorder. There are 3 types. Number 1 is clotting factor diseases. Number 2, hypercoagulation diseases. And number 3 is thrombocytopenia, with 2 major subtypes: idiopathic and thrombocytic purpura. The last group of clinical scenarios, this is malignancies. There are 3 major types: lymphomas, number 1; number 2, or multiple myeloma; and number 3 are leukemias. Leukemia are lymphocytic and myelogenous, and each one of them are 2 subtypes: acute and chronic. So let's start from number 1, which is anemias. So if they ask the question, what is the most likely diagnosis? So all the forms which can present with identical symptoms, they all of them have a decreased hematocrit. Symptoms are based on usually on severity of the disease, and you cannot answer what is the most likely diagnosis because this is simply based on the symptoms. Diagnostic test, usually we need a CBC. This is the best initial test for evaluation of anemia. Let's go over some numbers. The percentage of hematocrit and the symptoms. If the hematocrit is more than 30 to 35, no symptoms are expected. If it is between 25 and 30%, usually dyspnea, which is worsening on exertion, and fatigue. If it is 20 to 25, we can have chest pain or angina and lightheadedness. I'm sorry, I forgot to tell you. Let's go to the next slide. This is slide number 3, whatever we talk about. Let's go to slide number 4. If it is under 20 to 25, we have syncope and chest pain. Slide number 4 discuss some laboratory findings, but there is a clinical tip here that the cardiac ischemia due to anemia is frequently fatal. Myocytes in the heart cannot distinguish between anemia, hypoxia, CAD or coronary artery disease, and carbon monoxide poisoning. All these conditions result in decreased oxygen delivery to the tissues. So let's go over some lab findings. The first one is a mean corpuscular volume. We have to understand that if the CBC established the presence of anemia, the mean corpuscular volume, or MCV, is the first clue for the etiology of the anemia. We have here the first one is microcytosis. Microcytosis is there is 4 causes: iron deficiency, thalassemia, sideroblastic anemia, and anemia of the chronic disease. If we have microcytic anemias, is generally due to low reticulocyte count. Most causes of microcytosis have a production problem. Production problems are usually synonymous to a low reticulocyte count. Only alpha thalassemia with 3-gene deletion have elevated reticulocyte count. Wow. And here we need to remember this clinical tip. Routine blood smear will not be effective of telling the difference between the type of microcytosis. Let's go to the next slide, number 5. All of them will be hypochromic, and all of them will be potentially have target cells. There is another clinical tip here which state that sideroblastic anemia could be either microcytic or macrocytic. Let's go over, this is slide number 5. Let's go over some of the causes of high MCV. Number 1, this is B12 and folate deficiency. Number 2, sideroblastic anemia. Number 3, alcoholism. Number 4, anti-metabolite medications such as azathioprine, 6, mercaptopurine, or hydroxyurea. Number 5, this is liver disease or hypothyroidism. Number 7, some medications like zidovudine or phenytoin can cause this type of anemia. And the last one, this is number 8, MDS or myelodysplastic syndrome. We have here another clinical tip that all macrocytic anemia will give us low reticulocyte count. Also, we need to remember that the cold agglutinin can be falsely elevated, can falsely elevate MCV by so-called clumping cells. And the last one is so-called normocytic anemia. This is on the bottom of slide number 5. If we have acute blood loss or hemolysis, we'll have a drop of the hematocrit so rapid that there is no time for MCV to change. Blood loss ultimately leads to iron deficiency or microcytosis. Eventually, hemolysis will increase the reticulocyte count, which will rise the MCV since the reticulocytes are slightly larger than the normal cells. We need to know that methotrexate causes microcytic anemia, while RA or rheumatoid arthritis cause monocytic anemia. Let's go to the next slide, number 6. Number 6 slide, in the beginning there is a clinical tip which states that the blood loss or hemolysis will raise the reticulocyte count. How do we treat this type of clinical issues? I mean normocytic anemias. If the anemia is severe, we need to give the patient packed red blood cells, and answering the question, at what hematocrit do I transfuse a patient? This depends on the following factors. Number 1, is the patient symptomatic? Then transfuse. Number 2, is the hematocrit very low in the elderly or one with heart disease? Then transfuse. The answer is then transfuse. If there is another clinical tip which states that very low hematocrit between 25 and 30 in elderly or those with heart disease, you have to transfuse. There is another clinical tip which states here that symptomatic from anemia means, number 1, shortness of breath, number 2, lightheaded, confused, and sometimes syncope, number 4, hypotension and tachycardia, and number 3, and number 4, chest pain. There is another clinical tip here which states that we have to use IgA deficient donor, FFP, for IgA deficient recipients. And the last tip states that, remember, it is not necessary to transfuse anemia if the patient is young and asymptomatic. Let's go to the next slide. Slide number 7. What kind of blood products we have? We have several of them. The first one is packed red blood cells or packed RBCs, which is a concentrated form of blood. This blood product is a unit of whole blood with about 150 cc of plasma removed. The hematocrit of the PRBCs or packed red blood cells is about 70 to 80%. Because of the removal of plasma, the hematocrit is double the norm. Each unit of PRBCs should rise the hematocrit with 3 points per unit, or 1 gram per deciliter of hemoglobin. This is very important to remember. Then we have another blood product, which is FFP, or fresh frozen plasma, which is used to replace the clotting factors for those which are elevated, have elevated PT, activated PTT, or INR and bleeding. FFP is used to replace is used as a replacement for plasmapheresis. There is a clinical tip here which states that FFP is not a choice for those with hemophilia A and B, or VWD disease, or von Willebrand disease. The third blood product, this is cryoprecipitate. This product is used to replace fibrinogen and has some utility in DAC. It proves high amount of clotting factors. It provides a high amount of clotting factors in a smaller plasma volume. High levels of factor 8 and VWF, or von Willebrand factor, are found in this product. We need to remember there is a clinical tip. Cryoprecipitate is never used first for anything. Then we have another blood product, which is platelets. Platelets are pulled from the donation of multiple donors. They're given when the bleeding, when the patient is bleeding and the platelet count is less than 50,000. Platelet infusion is contraindicated for TTP. And we have a so-called PCC, or prothrombin complex concentrate, which has all the vitamin K factors used to reverse warfarin toxicity. There is a clinical tip which states that whole blood is never correct. Whole blood is divided into either PRBC or FFP. Let's go to the next slide. Let's discuss microcytic anemia. The definition of microcytosis is when the MCV is lower than the normal, which is usually below 80. The most common causes are 4 of them. Number 1 is iron deficiency, number 2 is chronic disease, number 3 is sideroblastic anemia, and number 4, thalassemia. Let's go over one of each. Iron deficiency, this is when we have a blood loss. We need to know that our body needs about a very tiny amount of iron, usually 1 to 2 milligrams per day. Menstruating women, they usually need a little bit more, between 2 and 3 milligrams per day. Pregnant women, they need a lot more, between 5 and 6 milligrams per day. We have to know that the duodenum can absorb up to 4 milligrams per day, which is about as little as 1 teaspoon per day of blood loss. Number 2, this is chronic disease. Chronic disease includes any form of cancer or chronic infection. Anemia of chronic disease is unclear by etiology. Usually the iron is locked in the storage and trapped in the macrophages or in ferritin. Hemoglobin synthesis will not occur uh, because of the iron just does not move forward. Uh, in, there is a precise mechanism which is clear only in renal failure when there is a deficiency of erythropoietin. Initially, MCV is normal, but then decrease. Uh, Hepcidin usually regulates the iron absorption. Hepcidin levels are low in anemia of chronic disease. Hepcidin is spelled Hepcidin. Then the third is sideroblastic anemia. Can be microcytic as well as when it's associated with myelodysplasia, which is known like pre-leukemic syndrome. In general, the most common cause is alcohol suppressive effect on the bone marrow. Less common causes are lead poisoning, isoniazide, and vitamin B6 deficiency. Sideroblastic anemia resulting from inability of the iron to be incorporated in the heme. And thalassemia, which is an extremely common cause for microcytosis. Mostly patients have thalassemia triad, and they usually are symptomatic. The lower part of the slide discuss when the question asks, what is the most likely diagnosis? We cannot distinguish between all these forms of anemia based on the symptoms. You have to have some suggestions from the history of the patient. However, to answer the most likely diagnosis for anemia, let's go to the next slide. There is a table on the top of the slide, slide number 9, which goes over these features of the history and the most likely diagnosis. If we have blood loss or GI bleed, it's usually iron deficiency. If we have menstruation, it's the same, usually iron deficiency. But number 3, if we have cancer or chronic infection, that's a chronic disease. RA or rheumatoid arthritis, that's a chronic disease. If we have alcoholism, usually it's sideroblastic. And if it is asymptomatic, it's usually thalassemia. We can do a peripheral smear on this patient, but usually this is not useful to differentiate different type of microcytic anemia. And usually this can be hypochromic or associated with target cells. The target cells are most commonly associated with thalassemia. There is a clinical tip here which states that unique finding on iron study are the best initial test for microcytic anemia. So we need to do is iron studies. On the lower part of the slide, discuss different types of iron studies, results, and possible diagnosis. If we have a low ferritin, is usually iron deficiency. If we have high iron, we have a sideroblastic anemia, and if we have normal iron study, it's usually thalassemia. Let's go to slide number 10. Slide number 10 discuss iron deficiency. If we have a low ferritin, and this is extremely specific for iron deficiency anemia, we need to remember that near 1/3 of the patient have a normal or increased ferritin, because of the ferritin is acute phase reactant. Also, we need to remember that we need to look also in the increase of the total iron binding capacity, or TIBC. This is a measure of unbound sites of transferrin. When there is a lot of open sites of transferrin, the capacity or unbound sites increase. So iron, usually all the other specific ferritin laboratory findings are decreased, except the TIBC, which is increased. When there is a lot of so iron divided by TIBC equals transferrin saturation. So this is the formula. And there is a clinical tip which states that the chronic renal failure routinely gives normocytic anemia. If we have a chronic disease, then the serum iron is low in the circulation because the iron is trapped in the storage. This is so-called store iron, which is elevated or normal. Circulating iron is decreased. However, the major point of difference is that TIBC is low. So in case of iron deficiency, TIBC is high, and chronic disease, the TIBC is low. In case of sideroblastic anemia, this is the only one and only form of microcytic anemia when the circulating iron level is elevated. In case of thalassemia, we have a normal iron studies. Let's go over some unique laboratory features. If we have an iron deficiency, in this case, RDW, or red cell distribution of width, is increased. This is because the newer cells are more, and the iron is deficient and smaller. At the body, if the body runs out of iron, the newer cells have less hemoglobin and get progressively smaller. In this case, there is elevation of the platelet count. And if there is a single most accurate test, this is a bone marrow biopsy with staining of the iron, which is decreased. This is rarely done, but is the most accurate test. Number two, if we have sideroblastic anemia, we do is Prussian blue staining, and this is we're looking for ring sideroblast, and this is the most accurate test. Basophilic stippling can occur in any cause of sideroblastic anemia. And if we have number three, thalassemia, the most accurate test, this is hemoglobin electrophoresis. In this slide, we will discuss that in thalassemia, in case of thalassemia, the hemoglobin electrophoresis is the most accurate test. We need to know that only 3 gene deletion alpha thalassemia is associated with hemoglobin H, and increase reticulocyte count. All the forms of thalassemia have a normal RDW. On the slide, figure 8.1, we'll see ring sideroblasts, which are detected by Prussian blue staining. There is a clinical tip which states that alpha thalassemia is only diagnosed with DNA analysis. On the next table, we can see the table which discuss different type of electrophoresis findings. Alpha thalassemia, there is if we have a one gene deleted, this is normal. For beta thalassemia, we have increased hemoglobin F and A2. If we have the two genes deleted, it will cause in alpha thalassemia mild anemia and normal electrophoresis. And if we have beta thalassemia, will not affect anything. If we have three genes deleted, we have moderate anemia with hemoglobin H, and in case of beta thalassemia, we have only beta thalassemia. Let's go to the next slide, slide number 12. If we have a beta 4 tetrads, we have increased reticulocytes. In this case, we'll have intermediate beta thalassemia. We'll have a normal hemoglobin F and also no transfusion dependency. In case that we have four genes deleted, we'll have a gamma 4 tetride or hemoglobin of Bart. And basically the CHF will cause death in utero. So for beta thalassemia, this is not applicable. There is a clinical tip here which states that only 3 gene deletion alpha thalassemia has a high reticulocytes. How do we treat that? In case of iron deficiency, we replace iron with oral ferrous sulfate. If this is not sufficient, we treat the patient with intramuscular iron. If we have a chronic disease, we need to correct the underlying cause. And if we have end-stage renal disease failure, we need to respond with erythropoietin replacement. In case that we have sideroblastic anemia, we need to correct the cause. Some patients respond to vitamin B6 or pyridoxine replacement. And this is why the isoniazide can lead to sideroblastic anemia. In case of thalassemia, the trite is not treated, but if we have beta thalassemia major, which is Cooley anemia, this is managed with chronic transfusion lifelong period. Iron overload is managed with deferoxyprone or deferoxyrox, which are both oral iron chelators. Deferoxyxamine is the parental version of the iron chelator. And there is a clinical tip which states that oral iron chelators are deferexy prone and deferexy rocks for, for hemochromatosis, which results from transfusion. Let's go to the next slide. Slide number 13. On this slide, slide number 13, there is a clinical vignette of a 73 years old man which comes to the office. He has a fatigue which becomes worsening in the last several months. Also, he has SOB. When he walks one flight upstairs, he drinks 4 vodka martinis a day. He has numbness and tingling in the feet. On physical exam, he has decreased sensation of his feet. Hemoglobin is 28 and his MCV is 114, which is elevated. Question is, what is the most appropriate next step of management? A, vitamin B12 level, B, folate level, C, peripheral blood smear, D, shearing test, E, methylmalonic acid level. Here is the right answer is C, because we have here macrocytic anemia, which is from B12 or folate deficiency, directly caused by alcohol effect on the bone marrow, or liver disease. The first step of this is peripheral smear. This is to detect hypersegmented neutrophils. Once the hypersegmented neutrophils is seen, then you're going to get B12 or folate levels. The clinical tip is that megaloblastic anemia is presented with hypersegmented neutrophils. Many other factors are erased as MCV, but only B12 and folate are deficient, and some anti-metabolic medication can cause hypersegmentation. Here we have to discuss the etiology of vitamin B12 deficiency. Number 1, pernicious anemia. Number 2, pancreatic insufficiency. Number 3, dietary deficiency such as strict vegan or strict vegetarian. Number 4, Crohn's disease, celiac disease, tropical sprue, radiation, or any other disease damaging the terminal ileum. Number 5, this is blind loop syndrome, which is caused by gastrectomy or gastric bypass for weight loss. And the last one, this is HIV, metformin, and diphyllobotulinum can cause also vitamin B12 deficiency. Let's go to the next slide, which is slide 14. Slide 14, we have a clinical tip which states that celiac disease can cause B12, folate, and iron deficiency anemia. Here, the folate deficiency can be caused by 3 scenarios, which is dietary deficiency. For example, goat milk has no poly and provides only limited iron and B12. Also, number two, psoriasis and skin loss or turnover, and drugs like phenytoin and sulfa. There is a clinical tip here, which if we use methotrexate for treatment of RA, probably we have a case of folate deficiency. We have to, if we have a question here related to presentation, the clinical presentation, and if the question asks what is the most likely diagnosis, we need to remember that alcohol can give, chronic alcohol abuse can give macrocytic anemia and neurological problems, but will never give us hypersegmented neutrophils. Another thing to remember is that B12 deficiency can cause also neurological abnormality, but the peripheral neuropathy is the most common. Dementia is the less common. Also, posterior column damage for positional and vibratory sensation or subacute combined degeneration is a classic symptom. Also look for ataxia. Regarding diagnostic tests, we need to know that there is a clinical tip here which states that only B12 deficiency is associated with increased methylmalonic acid level. Let's go to the next slide, slide number 15. On slide number 15, we'll see figure 8.2. We can see here hypersegmented neutrophils, how they look like. And this is the best initial test to determine the etiology of macrocytic anemia. Also, there is another laboratory abnormalities for both B12 and folate deficiency. Which include number one, megaloblastic anemia, number two, increased LDH and increased indirect bilirubin. Also, we can see decreased reticulocyte count. Also, we can see is hypercellular bone marrow. And the most important here, this is macrovalocytes. And also we will see increased homocysteine levels. So basically, B12 and folate deficiency are identically hematologically on the blood smear. There is a clinical tip here which states that B12 deficiency will see high LDH, high bilirubin, low reticulocytes, because of this is caused by ineffective erythropoiesis. On the bottom of the slide, there is a clinical scenario. About 73 years old woman comes with decreased positional and vibratory sensation of the lower extremity. The hemoglobin is 28, MCV is 114, and she has on laboratory finding hypersegmented neutrophils. Her B12 level is decreased, but the rest are normal. The question here is, what is the most appropriate next step of management of this patient? A, A is acid level. Let's go to the next slide, 16. B, it is anti-intrinsic factor antibodies. C, anti-parallel cell antibodies. D, shearing test. E, folate level. And F, homocysteine level. The right answer here is A. So on board exam, frequently our testing is for both B12 and folate deficiency, which will cause increase homocysteine levels, but only B12 is associated with increased MMA. When we have a story which suggests B12 deficiency and B12 level which are not equal, we need to use increased MMA level to confirm the diagnosis of B12 deficiency. Here there is another clinical tip which states that metformin is associated with B12 deficiency. Also, we need to know that the most frequently tested clinical facts for microcytic anemia, this is number 1, shearing test is never right answer. Number 2, pernicious anemia is confirmed with anti-intrinsic factor and anti-parietal cell antibodies. Number 3, red cells are destroyed as they leave the marrow, so the reticulocyte counts are low. Number 4, B12 and folate deficiency can cause pancytopenia as well as microcytic anemia. Number 5, pancreatic enzymes are noted to absorb B12. They are also free from carrier proteins. And number 6, neurological abnormality will improve as long as they are minor and they are in a short duration. The last clinical tip, this is that B12 will give us usually neurological or hematological abnormalities alone. Usually you don't have both. Let's go to the next slide. On slide 17, we have we'll start with treatment, and treatment is replaced if deficient. Folate replacement corrects the hematological problem in B12 deficiency, but not the neurological problems. If we have a question, what is the complication of B12 or folate replacement? Which of the following is a complication of B12 or folate replacement? A, seizure. B, hemolysis. C, hypokalemia. D, hyperkalemia. E, diarrhea. The right answer here is C, and the explanation is that extremely rapidly cell production in the bone marrow causes hypokalemia. There is no other condition in which cells are generated so rapidly that they use up all the potassium. Hyperkalemia from massive tissue or cellular breakdown has many causes, but hypokalemia from cell production is rare. So when you replace B12 or folate particular, if there is pancytopenia, cells in the marrow are produced so rapidly that the bone packs with potassium and lower the potassium level. So you need to observe and replace. The other clinical fact here is that pancreatic enzymes are needed to remove B12 from hard proteins so it can bind with the intrinsic factor. The next is hemolytic anemia. There are many forms of hemolysis. Number one, this is sudden decrease of hematocrit. B, increased level of LDH in the red bilirubin and reticulocytes. And C, decrease haptoglobulin level. D, slight increase of NCV. E, hyperkalemia from cell breakdown. D, A, B, C, D, E, G, folate deficiency from increased cell production. We know that the folate stores are very limited. Let's go to the next slide. This is a clinical fact in the beginning of this slide, number 18, which states that chronic hemolysis is associated with bilirubin gallstones. Next topic is sickle cell disease. Sickle cell is caused by a point mutation at position 6 in the beta globulin chain, which valine is replaced with glutamic acid. By definition and etiology, sickle cell is a chronic, usually well compensated hemolytic anemia with reticulocyte count which is always high. Acute painful vaso-occlusive crisis is caused by 1. Hypoxia, 2. Dehydration, 3. Infection or fever, 4. Cold temperature. If the clinical vignette asks what is the most likely diagnosis, you need to look for African American patient with sudden severe back in the chest, severe pain in the chest, back and the thighs, which is accompanied by fever. It is rare for an adult to present with acute crisis without a clear history of sickle cell disease. Which are the other most common manifestations of sickle cell disease? This includes bilirubin gallstones, which are chronically due to chronically elevated bilirubin levels. 2. Increased infection from autosplenectomy, particularly encapsulated organisms. 3. Osteomyelitis. The most common is from Salmonella. 4. This is retinopathy. Let's go to the next slide. Five, this is stroke. 6, this is enlarged heart with hyperdynamic features and systolic murmur. 7, this is lower extremity skin ulcers. And 8, avascular necrosis of the femoral head. The X-ray is the first test, the MRI is the most accurate. There are few clinical facts which we need to remember. Number 1, children present with dactylitis, which is inflammation of the fingers. 2, papillary necrosis of the kidney happen with chronic kidney damage. diagnostic tests for sickle cell anemia. The best test is peripheral smear. If we have a sickle cell trait or HE disease, this does not give sickle cells. The most accurate test in hemoglobin is the hemoglobin electrophoresis. Uh, if the question asks what the lower the mortality of sickle cell disease, number one, this is hydroxyurea for prevention and antibiotics for fever. Let's go to the next slide. Slide number 20. On figure 8.3, we see target cells, sickle cells, and platelets, which can occur, target cells can occur in many hematological diseases, including sickle cell disease. If the question asks which of the following can be found on smear of sickle cell disease, A, basophilic stippling, B, Howe-Jury bodies, C, bite cells, D, schistocytes, E, Moru. The right answer here is B, and the explanation is the following. These are participating remnants of nuclear material seen inside of the red cells of a patient who does not have a spleen. There is no change in therapy or management based on the presentation of Howe-Jury bodies. Basophilic stippling is associated with a number of causes of sideroblastic anemia, especially lead poisoning. Bite cells are seen in glucose 6 deficiency, phosphate deficiency. Schistocytes are fragmented red cells which are seen in intravascular hemolysis. Morule are seen inside neutrophils in infection with Escherichia. The treatment for sickle cell anemia is the following. There is a clinical tip which we need to remember. Nucleated red blood cells are found in premature release of precursor blood cells. And the treatment is the following. Number one, begin with oxygen, hydration, and analgesia. Two, if the fever or the white cells are high, then the usual, give antibiotics. Use ceftriaxone, levofloxacin, and monofloxacin. 3. Folic acid needs to be replaced. This is necessary for the on chronic base. 4. Give pneumococcal vaccine because of the autosplenectomy. And 5. Hydroxyurea prevents recurrence of sickle cell crisis by increased hemoglobin F. Increase the dose of, we need to know that increase of the dose of hydroxyurea until the hepatocytes growth factor or HGF level rise 10 or 15%. If the WBCs are low, do not increase the dose. Here there is a clinical tip we have to remember. Do not wait for the results for testing to start antibiotics if there is a fever. The absence of functional spleen leads to overwhelming infection. And another clinical fact, this is that exchange transfusion is used if a severe vaso-occlusive crisis presents with number 1, acute chest syndrome, 2, priapism, 3, stroke, 4, visual disturbance from retinal impact. Sorry, this is on the next slide, 21. I apologize. Then we need to discuss aplastic crisis. We have here a clinical vignette of 43 years old man with sickle cell disease, which is admitted with acute chest pain, with acute chest painful crisis. His only routine medications are folic acid. His hematocrit is 34. On the third hospital day, the hematocrit drops to 22. The question is, what is the best initial test? A, reticulocyte count, B, peripheral smear, C, folate level, D, parvovirus B19 IgM level, and E, bone marrow. The answer of this clinical vignette is A, and the explanation is that patients with sickle cell disease usually have a very high reticulocyte count because of the chronic compensated hemolysis. Parvo B19 causes an aplastic crisis which freezes the growth. Let's go to the next slide. Number 22. The growth of the marrow. Nothing will be visible on the blood smear. Although the bone marrow will be shown giant pro-normoblast, this would not be done routinely and certainly never as an initial test. The first clue to parvovirus is sudden drop of a reticulocyte level. The most common, most accurate test for parvovirus B19, that's PCR for DNA. The most accurate, this is the most accurate than IgM level. IV immunoglobulin is the best initial therapy. If we have a patient with sickle cell trait, this means that the patient is heterozygous for sickle gene, AS. The only manifestation for sickle cell triad, this is defect inability to concentrate the urine or isotenuria. They are clinically asymptomatic and they have both normal CBC level and normal smear results. Hematuria may be sometimes occur. There is no treatment for sickle cell trait. Next clinical scenario topic is hereditary spherocytosis. The etiology for this is defect of the skeleton of the red cell leading to abnormal round shape and loss of normal flexibility, which is pretending to concave disc, which allow the red cells to bend in the spleen. If the question asks what is the most likely diagnosis, 1, there is a recurrent episodes of hemolysis, 2, intermediate jaundice, 3, splenomegaly, 4, family history of anemia or hemolysis, and 5 bilirubin gallstones. The diagnostic test for this is 1. Low MCV. Let's go to the next slide. Increase mean corpuscular hemoglobin concentration or increase MCHC, and 3. Negative Coombs test. The most accurate test is Elzin 5 malanamide flow cytometry. It is more accurate than osmotic fragility testing, in which the cells are placed in hypotonic solution and there is increased swelling of the cell leading to hemolysis. On figure 8.4, you see spherocytes which lose the central power of the normal red cells. And in this case, the MCHC is elevated. The treatment is chronic folic acid replacement and splenectomy. The next topic is autoimmune warm or IgG hemolysis. The etiology for this is 50%. There is no etiology, but the clear causes are the following. 1. Chronic lymphocytic leukemia or CLL. 2. Lymphoma. 3. SLE or systemic lupus erythematosus. And 4. Drugs such as penicillin, alpha-methyl-dopa, rifampin, phenytoin. Let's go to the next slide, slide 24. The diagnosis for this. The most accurate test is the Coombs test, which basically detects IgG antibodies on the surface of the red cells. There is 2 types, direct and indirect Coombs test, which basically tells you the same thing. But the indirect test is associated with greater amount of antibodies. The autoimmune hemolysis is also associated with spherocytes. This is a clinical tip. So autoantibodies remove small amount of red cell membrane and lead to a smaller membrane and forcing the cells to become round. Biconcave disc needs a greater surface area than the sphere. Autoimmune hemolysis is associated with macrospherocytes. There is a clinical tip here, which means that the smear does not show fragmented cells in autoimmune hemolysis because of the red cells destruction occur inside the spleen or liver, not in the blood vessel. The treatment is there's a few types of treatment. Glucocorticosteroids, such as prednisone, is the best initial therapy. 2. Recurrent episode respond to splenectomy. 3. Severe acute hemolysis. If the severe acute hemolysis does not respond to prednisone, we have to give IVIG. And 4. Rituximab, azathioprine, cyclophosphamide, or cyclosporine are used when splenectomy does not control the hemolysis. And the so-called Adams 13 level is low if in case of TTP. There is so-called alternative treatments. If the need for steroids are diminished. One is cyclophosphamide, two, cyclosporin. Let's go to the next slide, 25. Three, azathioprine, and four, mycophenolate mofetil is number 4. Also on slide 25, we'll talk for cold agglutinin disease. By definition and etiology, co-agglutinins are IgM antibodies, which are against the red cells, which are developing in case of Epstein-Barr virus, Waldenstrom microglobulinemia, or Mycoplasma pneumoniae. The presentation is symptoms occur in the colder parts of the body, such as numbness or melting of the nose, ears, finger, and toes. Symptoms resolved by warming of the body part. Diagnosis is that so-called Adams 13 is low in case of TTP, EDAMTS. The direct Coombs test is positive only for complement, the smear normal, or may show only spherocytes. Co-agglutinin titer is the most accurate test. The treatment is the following. 1. Keep the patient warm. 2. Administer rituximab or sometimes plasmapheresis. And 3. Cyclophosphamide, cyclosporin, or other immunosuppressant agent, which are designed to stop the production of antibody. There is a clinical tip here. Let's go to the next slide, 26. Which state that steroids and splenectomy do not work in co-agglutinin disease. And prednisone is the most common wrong answer. Next clinical tip is that cryoglobulins are often mixed with cold agglutinins. Although both are IgM, but they do not respond to steroids. Cryoglobulins are associated with 1. Hepatitis C, 2. Joint pain, 3. glomerulonephritis. On this slide number 26, we have to discuss G6PD, or glucose 6-phosphate dehydrogenase deficiency. Let's start with etiology. This is an X-linked recessive disorder leading to inability to generate glutathione reductase, which is designed to protect the red cells from oxidant stress. The most common oxidant stress, this is infection. Another cause is dapsone, quinidine, sulfa drug, primaquine, nitrofurantoin, and favabeans. If the question asks what is the most likely diagnosis, we have to look for African American or Mediterranean men with sudden anemia and jaundice, which have a normal size spleen with infection, or are used one of the drugs previously listed. Clinical tip here is because of G6PD deficiency is X-linked recessive, It manifests almost exclusively in men. The diagnosis, and we'll see clinical tip is here, we'll see Heinz bodies on a special stain which is methylene blue. Let's go to the next slide. Slide 27. As we mentioned before, the best initial test is Heinz bodies and bite cells. The G6PD level will be normal after a hemolytic event. The most accurate test is G6PD level after waiting 1 or 2 months after the acute episode of hemolysis. On figure 8.5, we see how the bite cells look like. The treatment is nothing reverse the hemolysis. We just need to avoid oxidant stress. The next clinical topic which we need to discuss, this is HOS, or hemolytic uremic syndrome, and TTP, which is thrombocytopenic purpura. These are different versions of the same basic disease caused by deficiency of so-called metalloproteinase Adams 13. HOS is associated with E. coli 0157/H7, and it's more frequent in children. TTP is associated with teicoplanin, clopidogrel, cyclosporid, AIDS, and SLE. Both disease presents with one intravascular hemolysis with fragmented red cells which are schistocytes, 2 thrombocytopenia, 3 renal insufficiency. Let's go to the next slide. TTP is also associated with neurological disease and fever. It's more common in adults. Neurological symptoms include confusion and seizures. There is no any specific test to diagnose this disease, both disease. HOS and TTP are both. They have normal PT, PTT, and negative Coombs test. Several cases are treated with plasmapheresis or plasma exchange. Cases which are patients which are not related to drugs or diarrhea can be treated with steroids. Also, there is another clinical tip here which states that if there is no delay to plasmapheresis, infuse FFP. Another clinical tip states that do not transfuse platelets into patients with HOS or TTP. Platelet transfusion worsens the disease. Another clinical topic on slide 28, this is paroxysmal nocturnal hemoglobinuria. Hemoglobinuria, or PNH. PNH is a clonal stem cell defect which increases the sensitivity of the red cells to complement in case of acidosis. This is because there is a complement regulatory proteins like CD15 55 and 59, which are known as decay accelerating factors. The gene for so-called PIK-A or phosphatidylinositol class A is defective. This leads to overproduction of the complement system. This does nothing to the affected person, but PNH leads to hemolysis and thrombosis. How the patient presents and what is the most likely diagnosis. Most frequently, patient presents with episodic dark urine, number 1, number 2, pancytopenia, and iron deficiency anemia. There is a clinical fact here which states that PNH is a stem cell defect which can cause aplastic anemia, myelodysplasia, or acute leukemia. Let's go to the next slide, slide number 29. Slide 20, number 29 starts with that the clots are in very unusual places. This means that they are not just DVT or PE. There is a clinical tip here which states that thrombosis is the most common cause of death. Wow. A diagnostic test, usually CBC, shows pancytopenia plus anemia. The most accurate test, this is decreased level of CD55 and CD59. You can do also here flow cytometry. The treatment is with prednisone, which is the best initial therapy. Number 1, number 2, allogenic bone marrow transplant is the one and only method of cure. And 3, eculizumab inactivates C5 in the complement pathway and decrease the red cell destruction. Basically, this is complement inhibitor. Eculizumab is good for hemolysis and thrombosis. Also, we need to have remember here a clinical tip that we need to give a meningococcal vaccine prior to eculizumab. And number 4, give folic acid and replacement with transfusion if needed. Another thing is, clinical tip is that large vessel thrombosis of the mesenteric and hepatic veins is the most common site of thrombosis. So we're talking about this unusual site of thrombosis. And with slide 21, we conclude the part of anemias. Let's take a little break.
800 paying law. Are you looking for this voucher? Do you have bad credit or no credit and are afraid you don't have enough cash? Then
Okay, let's talk about aplastic anemia on slide 30. Aplastic anemia, this is pancytopenia with unclear etiology. Any infection or cancer which can invade the bone marrow can cause decreased production or hypoplasia. The other cause of Pancytopenia are radiation and toxins, such as toluene, DDT, benzene, drug effects, such as sulfa, phenytoin, carbamazepine, chloramphenicol, alcohol, chemotherapy. Other etiologies are SLE, PNH, infection as HIV, hepatitis, CMV, and EBV. Other options are etiology options are B12 and folate deficiency, and also some thyroid inhibiting medications such as PTU and metimazole. How the patient presents and diagnosis. Patient they presents with fatigue from the anemia, infections which presents with a low white count, bleeding from the thrombocytopenia. The most accurate test, this is a bone marrow biopsy. The treatment, there is a clinical tip here that the aplastic anemia acts as an autoimmune disorder in which the T cell attack the patient's own marrow. Treatment is based on medication such as cyclosporine, which inhibit the T cells. This brings the bone marrow back to life. Supportive therapy such as blood transfusions for anemia, antibiotics for infection, platelets for bleeding should be used to treat the underlying cause. The true aplastic anemia can be treated with allogenic bone marrow transplant. Let's go to slide 31, or the abbreviation is BMT. If the patients are young enough and there is a matched donor. If the patients are too old for BMT, above age of 50, and there is no matched donor, the treatment is with ATG or anti-homocysteine globulin and cyclosporine. The tacrolimus is alternative of cyclosporine, and alemtuzumab is the anti-CD52 agent which suppresses the T cells. Let's discuss slide 31, which describes polycythemia vera. Polycythemia vera is unregulated overproduction of the T cell lines, but the red cell overproduction is most prominent. This is caused by mutation of JAK2 protein, JAK2 protein, which regulates the bone marrow production. The red cells grow widely despite of the low erythropoietin level. What is the most likely diagnosis? The patient usually presents with symptoms of hyperviscosity, which means increased red blood cell mass, such as 1. Headaches, blurry vision, and tinnitus. 2. Hypertension. 3. Fatigue. 4. Splenomegaly. 5. Bleeding from engorged blood vessels. And 5. Thrombocytosis from hyperviscosity. Also, there is a pruritus, which follows the warm showers because of the histamine release from the increased number of basophils. Let's go to the next slide, 32. The hematocrit is markedly elevated over 60%, and the platelets and the white cell counts are openly elevated also. Uh, we must exclude hypoxia, which is a cause of erythrocytosis. The total red cell mass is elevated, oxygen levels are normal, and erythropoietin levels are low. Also, the vitamin B12 levels are elevated for unclear reasons. The most accurate test is JAK2 mutation, which is found in 95% of the patients. Also, there is increased numbers of basophils, and a small number of patients can convert to AML. A clinical tip here is that renal cell cancer can be associated with elevated hematocrit, but erythropoietin levels are elevated in kidney cancer. We need to remember that the MCV is low in polycythemia vera. How do we treat these patients? We give the patients phlebotomy, frequent phlebotomies and aspirin to prevent thrombosis. Number one. Number two, hydroxyurea to lower the cell count. Platelet counts are elevated temporarily after the spleen is removed. Then we can give also allopurinol or rasburicase to protect against uric acid elevation. And also we can give the patient antihistamines. The target goal for hematocrit will be less than 45%. Rucoxilitinib is the inhibitor of JAK. If the question describes failure of hydroxyurea, the answer is rucoxitinib. Let's go to the next slide, 33. Here we need to discuss so-called essential thrombocytosis. Essential thrombocytosis, this is when we have markedly elevated platelet count above 1 million, which lead both to thrombosis and bleeding. Essential thrombocytosis, or ET, is very difficult to distinguish from elevated platelet count, which is a reaction to another stress such as infection, cancer, or iron deficiency. The treatment, if the patient is less than 60 years old and asymptomatic, platelet count under 1.5 million, no treatment necessary. If the patient is above 60 and the platelet count is above 1.5, start treatment. The best initial therapy is hydroxyurea. Anagrelid is used when there is a red cell suppression from the hydroxyurea. Aspirin can be used for erythromegaly. Also, this medication named ruxolitinib can inhibit JAK2, JAK2. JAK2 mutation is found in 50% of ET cases. Wow. Next clinical topic, this is myelofibrosis. This is a disease of older person with pancytopenia associated with bone marrow showing marked fibrosis. Blood production shifts to spleen or liver, which become markedly enlarged. Look for teardrop-shaped cells and nucleated red blood cells on the blood smear. Thalidomide and the other one is lenalidomide are tumor necrosis factor inhibitors, which will increase the bone marrow production. In some occasions, patients which are under 50-55, allogeneic bone marrow transplant can be attempted. Also, we need to know that ruxolitinib inhibits the JAK2 and suppresses the myelofibrosis. Slide 34, we will discuss acute leukemia. Usually patients with acute leukemia presents with sign of pancytopenia. Usually they have fatigue, infections, bleeding. Even the white blood cells count is normal or increase in many patients. Despite increase of white cell count, infection is common presentation because of leukemic cells, the blasts, do not function normally in controlling the infection. There is a clinical tip which states that if we're looking for history of myelodysplastic syndrome, this will suggest acute leukemia. The most frequent tested type of acute leukemia, this is M3 or acute promyelocytic leukemia. This is because of the promyelocytic leukemia is associated with DAC or disseminated intravascular coagulation. There is no distinct clinical presentation between type 3, 3 subtype of acute lymphocytic leukemia, ALL. So there is no point of learning the differences between them. There is a clinical tip here which states that the best initial test, this is blood smear showing blasts. And another clinical tip is that M3 is associated with translocation between chromosome 15 and 17. The most accurate test, this is a flow cytometry which distinguish different subtypes of acute leukemia. The flow cytometry is a method which detects specific CD subtypes associated with each type of leukemia. Myeloperoxidase is characterized with acute myelocytic leukemia, AML. Also, there is a clinical tip which states that IRODs are eosinophilic inclusions associated with AML. M3 or acute promyelocytic leukemia is most commonly associated with IRODs. Let's go to the next slide. There is on slide 42, there is a clinical tip which states that which is less dangerous, thrombocytopenia and anemia from autoimmune effect, or marrow infiltration with CLL cells. The answer is autoimmune effect. This can be treated with prednisone, and it is not the same as for stage 3 and 4 in stage 4 disease. Let's discuss here hair cell leukemia, or HCL. This type of leukemia presents usually in middle-aged men and presents with the following: pancytopenia, number 1, number 2, massive splenomegaly, number 3, monocytopenia, and number 4, dry tap, despite the hypercellularity of the bone marrow. There is a clinical tip here which states that in hair cell leukemia, B cells with filamentous projections are seen on smear. The best initial test, this is a smear which shows hair cells. The most accurate test, this is immunotyping with flow cytometry, and this type of leukemia is treated with quadribine or pentostatin. Next clinical topics which we need to discuss, this is non-Hodgkin lymphoma. By definition, NHL or non-Hodgkin lymphoma, this is proliferation of lymphocytes. Let's go to the next slide, slide 43. Proliferation of lymphocytes in the lymph nodules and spleens. This is most often widespread at presentation and can affect any lymph nodule or organ which has a lymphoid tissue. NHL and CLL are extremely similar, but NHL is a solid mass and CLL is liquid or circulating. What is the presentation? And if the question asks what is the most likely diagnosis, we need to know that number 1, this is a painless lymphadenopathy. Number 2, nodes are warm, red, or tender. It may involve the pelvic, retroperitoneal, and mesenteric structures. And number 4, there is so-called B symptoms: fever, weight loss, night sweats. Infection, not NHL, gives the nodule the fact that they are warm, red, and tender. The diagnosis, the best initial test, this is excisional biopsy. CBC is normal in most cases. We can see high LDH levels, which correlates with worsening of the severity. Staging is determined, so can be better treated. Staging of non-Hodgkin lymphoma does not change the treatment because in most cases they are widespread, stage 3 and 4. Typical staging procedures are, bless me, CT scan of the chest, abdomen, and pelvis, and number 1, and number 2, bone marrow biopsy. There is a clinical tip which states that the most common wrong answer is to do a needle aspiration of the lymph nodes. Aspiration is not enough because of the individual lymphocytes appear normal. And let's talk about the staging. Stage 1, this is one lymph node group. Stage 2, two or more node groups on the same side of the diaphragm. Stage 3, both sides of the diaphragm are involved. Let's go to the next slide, which is slide 44. Stage 4 is a widespread disease. The treatment depends from the staging. Local disease, which is stage 1A and 2A, needs the only local radiation and small dose of course of chemotherapy. Advanced disease, which is 3, 4, and any B symptoms, we give the patient combination of chemotherapy with CHOP and rituximab, which is antibody against CD20. CHOP, C-H-O-P, means stands for cyclophosphamide, H for adriamycin or doxorubicin or hydroxyrubicin. O stands for vincristine or oncovin, and P for prednisone. We need to remember here that 80 to 90% of the cases with NHL presents in advanced stages. And there is so-called mucosal associated lymphoid tissue. If there is a lymphoma of the stomach, is usually associated with H. pylori. Treatment of Helicobacter with clarithromycin and amoxicillin is necessary. Let's talk about Hodgkin disease. By definition, presentation, diagnostic test, B symptom and staging. HD or Hodgkin disease is the same as NHL. HD has so-called Reed-Steinberg cells on pathology. And here on the bottom of the slide, number 44, there is a very nice table, the differentiations between the Hodgkin disease and non-Hodgkin lymphoma. Hodgkin disease usually is local, stage 1 and stage 2 in 80 to 90%. Non-Hodgkin lymphoma is usually stage 3 and 4 in 80 to 90%. Let's go to the next slide. Stop it. Non-Hodgkin disease, usually the centers are around the cervical area, and for the other case, non-Hodgkin lymphoma is disseminated. HD usually presents with Reed-Steinberg cells on pathology, and non-Hodgkin lymphoma, there is no Reed-Steinberg cells. Hodgkin lymphoma, there is a pathological classification. If it's predominantly lymphocyte predominant, is the best prognosis. Uh, if it is lymphocytic depleted, is the worst prognosis. For non-Hodgkin lymphoma, the pathological classification is Burkitt, and immunoblastic have the worst prognosis. Let's talk about the treatment. Stage 1A and 1 and 2A. Usually, we give local radiation with small course of chemo. For stage 3 and 4, or any B symptoms, we need to give patient ABVD, which is A stands for adriamycin or doxorubicin, B for bleomycin, V for vinblastine, and D for dacarbazine. Wow. So ABVD treatment. There is a clinical tip which states that relapses after radiation therapy is treated with chemotherapy. Relapses after chemotherapy are treated with extra high dose of chemo and bone marrow transplant. Let's discuss here the complications of radiation and chemotherapy. The radiation usually increases the risk of solid tumors such as breast, thyroid, and lung cancer. Screening for breast cancer is recommended 8 years or more after treatment. Also, radiation increases the chances of premature coronary artery disease, premature CAD, and the risk of acute leukemia, MDS, or NHL as a complication of chemotherapy is about 1% per year. And here let's discuss a clinical vignette which is asking which is the following is the most useful to determine dosing for chemotherapy in HD or Hodgkin disease. A. Echocardiogram. B. Bone marrow biopsy. Let's go to the next slide, 46. C. Gender. D. Muga scan or nuclear ventriculogram. E. Hematocrit. F. Symptoms. Radiation alone is never right for lymphoma. This is a clinical tip. The answer for this question is D. Muga or nuclear ventriculogram. And the explanation is the following. Adriamycin or doxorubicin is the cardiotoxic. Nuclear ventriculogram is the most accurate method of assessing left ventricular injection fraction. Muga scan is to determine the cardiac toxicity which occur prior to developing of the symptoms. You cannot use adriamycin if the injection fraction is less than 50%. On this slide, there is a very nice table for side effects of the chemotherapy. The doxorubicin can give a cardiomyopathy. Vincristine can cause neuropathy. Bleomycin, lung fibrosis. Cyclophosphamide, hemorrhagic cystitis, and cisplatin, renal, and ototoxicity. All of these side effects could be a board review question. Next topic to discuss, this is multiple myeloma or MM. By definition, myeloma is abnormal proliferation of plasma cells. These plasma cells are unregulated in their production unless um, with useless immunoglobulin, which is usually IgG or IgA. IgM is a separate disease called Waldenstrom microglobulinemia. All these immunoglobulin cannot fight infection, but they clog the kidney. Let's go to the next slide. 47. If the clinical scenario is asking what is the most likely diagnosis, the most common presentation of MM is a bone pain from different pathological fractures. Uh, Usually, a pathological fracture means that the bone breaks under what is considered normal use. This is from osteoclast activating factor or OAF, which is considered normal use. Uh, when OAF attack the bone, it causes lytic lesion. OAF is also a reason for hypercalcemia. Infections are also common because of the abnormal plasma cells do not make immunoglobulin, which are effective against infection. The presentation is hyperuricemia due to increased turnover of nuclear material, anemia due to infiltration of the bone marrow with massive numbers of plasma cells, and number 3, renal failure, which is due to accumulation of immunoglobulins or Ben-Jones proteins into the kidney. Hypercalcemia and hyperuricemia also damage the kidney. We need to remember that the renal failure and infections are the most common cause of death of MM, patients with MM. Diagnosis is the first test, which we usually is X-ray of the affected bone, which shows lytic punch-out lesions. Let's go to the next slide, which is slide 48. We see on figure 88 and 89 myeloma. The MRI shows bone infarcts on the left side and lytic lesions on the skull. Also, we need to know that so-called SPEP or serum protein electrophoresis will show IgG about 60% or IgA 25% spike on a single type or clone. This clone is called monoclonal or M-spike. About 15% of the light chains or Ben-Jones proteins are only presented. Additional lab findings are hypercalcemia, Ben-Jones proteins, beta-2 microglobulin levels, smear with Rolex, elevated BUN and creatinine. Bone marrow biopsy shows 10% plasma cells and elevated total protein with normal albumin. In MM, we have decreased anion gap. IgG is cationic. Increased cationic substances will increase chloride and bicarb levels, and this will decrease the anion gap. Let's go to the next slide. Here there is a clinical tip which states that Rolex formation is when the IgG paraprotein sticks to the red cells, causing them to adhere to each other, and they form stacks or rows. On figure 8/10, we see plasma cells on a myeloma. The lucency or light area near the nucleus is so-called hub, which is Golgi apparatus usually. Let's do a clinical vignette. Question is asking is, what is the explanation of the differences between urinary level of protein on urine analysis and 24 hours urine? A, it's a false positive 24 hours urine, common for myeloma. B, calcium in urine, creatinine is falsely negative on urine analysis. C, uric acid creates a false positive 24 hours urine. D, Benz-Jones protein is not detected by dipstick. And E, IgG on urine inactivates the urine dipstick. And the right answer here is D, Benz-Jones protein is detected by urine immunoelectrophoresis. The urine dipstick will detect only albumin. Next clinical scenario is asking what is the single most accurate test for myeloma? A, skull X-ray. B, bone marrow. C, 24 hours urine. D, SPEP, S-P-E-P. And E, urine immunoelectrophoresis or Benz-Jones protein. The right answer here is B. Nothing beside myeloma is associated with greater than 10% plasma cells on the bone marrow biopsy. Let's go to slide number 50. 8 more slides. So we're almost over. The treatment, the best initial therapy is combination of dexamethasone and lenalidomide or both. Multiple myeloma therapy is in a stage of rapid flux due to numerous advances. Melphalan is useful in older, fragile patients who cannot tolerate side effects. The most efficient therapy for those which are under 70 years old is autologous bone marrow transplant with stem cell support. This is used after induction of chemotherapy with lenalidomide and steroids. So-called daratumumab is the anti-CD38 drug which is used in case of relapse. Let's discuss so-called monoclonal gammopathy with unknown significance. If on SPEP we see spikes of IgG or IgA, they're more common in older patients. The main issue here is that we need to do a bone marrow biopsy to exclude myeloma. Monoclonal gammopathy of unknown significance, or so-called MGUS, has small numbers of plasma. You have a small numbers of plasma cells. There is no therapy for MGUS, although about 1% a year they transform to myeloma. Let's talk about so-called Waldenstrom macroglobulinemia. This is the bottom of slide 50. This is when we have overproduction of IgM from malignant B cells, which cause hyperviscosity. Let's go to the next slide, 51. This can cause lethargy, blurry vision, and vertigo, engorged blood vessels of the eye, mucosal bleeding, and rhinopneumia. Anemia is very common, but IgM spike on SPEP results in hyperviscosity. Plasmapheresis is the best initial therapy to remove the IgM and decrease the viscosity. Long-term treatment with rituximab and prednisone cyclophosphamide. These control the cells, which make them they make the abnormal immunoglobulin. Decrease the meaning of the decrease. It means the decrease of the production. You can use bortezomib or lenalidomide as it is in case of myeloma. And we reach the so-called bleeding disorders. This is the number 3 part of our lecture, but let's take a quick break. Let's talk about bleeding disorder. The first step for evaluation for bleeding is determining if the bleeding seems related to platelets or clotting factors. Bleeding of the brain or GI system can be either from platelet or clotting factor deficiency. Here there is a nice table. For different type of bleedings. Superficial bleeding, we have deep bleeding, epistaxis, gingival, petechial, purpura, mucosal services such as gums, vaginal bleeding. We're talking about joint and muscles. Let's go to the next slide, slide number 52. Slide 52 will discuss so-called ITP or immune thrombocytopenic purpura. If the question asking what is the most likely diagnosis, we can say that it's we need to look for isolated thrombocytopenia, which means normal hematocrit and normal WBC count. Also, we need to look for normal size spleen. Let's go over clinical vignette. We have a 23 years old woman comes to ER with markedly increased menstrual bleed, gum bleeding when she brushes her teeth, and petechiae on a physical examination. A physical exam is usually otherwise normal. Platelet count is 17,000. The question asked is, what is the most appropriate next step of therapy? A, bone marrow biopsy. B, IVIG. C, prednisone. D, antiplatelet antibodies, and E, platelet transfusion. The right answer here is C. The bleeding in this case is mild, meaning that there is no intracranial bleed or major GI bleed, and the platelets are not profoundly low. Prednisone is the best initial therapy. If we initiate prednisone, this is the most important that we need to be checking for increased megakaryocytes or presence of antiplatelet antibodies, which is typical for ITP. Bone marrow is rarely needed. So let's talk about diagnosis of ITP. ITP is diagnosis of exclusion. We need to do so-called antiplatelets antibodies. They lack specificity and they have a limited benefit. And this test has a limited benefit. Then we can do is ultrasound or CT scan, which will exclude hypersplenism. Number 3, megakaryocytes are elevated in numbers. Number 4, bone marrow is not a routine test. It's only indicated before splenectomy. And number 5, we'll see elevated mean platelet volume. Here there is a clinical tip that two medications here, which is one is romiplostin and eltrombopag, synthetic thrombopoietin for ITP. Let's discuss slide 53. There is a very nice table which discusses the presentation with the management. If the no bleeding, the count is over 30,000, no treatment necessary. This number 1 scenario. Number 2 scenario, if we have mild bleeding, the count is less than 30,000. The treatment will be glucocorticosteroids. Number 3 scenario, if we have severe bleeding, GI or CNS, and the count is less than 10,000, we need to treat with IVIG and anti-D or anti-RO. And number 4 scenario, if we have recurrent episodes and steroid-dependent patient, we need to do splenectomy. And number 6 scenario, if splenectomy or steroids are not effective, we need to start the patient on several medications such as romiplostin or eltrombopag, rituximab, azathioprine, cyclosporin, or mycophenolate. Here there is a clinical tip which states that before splenectomy, we need to give vaccination for number 1, Neisseria meningitis, number 2, Haemophilus influenza, number 3, pneumococcus. Let's discuss now so-called VWD or von Willebrand disease. Let's go to the next slide. For so-called factor 11 deficiency, most of the time there is no increase of the bleeding with factor 11 deficiency. Usually after trauma or surgery, we have increased bleeding. We need to look for normal PT and prolonged PTT. Usually the mixing studies will correct the PTT to normal. Let's go to the next slide, 55. No. 54. Sorry, we need to go back to slide 54. And there is a very nice table. Hold on a second. Let's pause for a second. Slide 56. So basically, this slide, we have to look for elevation of both PT and PTT. We need to look for low plate count and elevated D-dimer and fibrin split products. Also, we need to see decreased fibrinogen level. The treatment is the following. If the platelets are under 50,000 and the patient is seriously bleeding, we need to replace the platelets as well as the clotting factors by using FFP. Heparin has no benefit. Cryoprecipitate may be effective to replace the fibrinogen level if the FFP does not control the bleeding. Let's discuss so-called APL syndrome or hypercoagulated states thrombophilia. The only thrombophilia important for the test for the boards, the PA and MP boards, this is so-called APL syndrome. The most common cause is a factor 5 Leiden mutation. There is no difference in intensity of anticoagulation. We can use warfarin for INR of 2 for 3 to 6 months. Let's discuss so-called heparin-induced thrombocytopenia or HIT. It's more common with the use of unfractionated heparin, but it can still occur with the low molecular weight heparin. HIT presents on day 5 to 10 days after the start of heparin and will notice a marked drop in the platelet count, more than 30%. Both venous and arterial thrombosis can occur, although venous clots are more common. HIT rarely lead to bleeding. The platelets are just precipitating out. Let's go to the next slide, slide number 57. APL is the most likely to need lifelong warfarin with even one only clot. And this is the clinical tip. The diagnostic tests, HIT is confirmed by ELISA for platelet factor 4, PF4 antibodies, or serotonin release assay. The treatment, number 1, we need to stop all the heparin-containing products. Number 2, we need to administer direct thrombin inhibitors such as argatroban, bivalirudin, and fundaparinux. The last one is very easy to use. And number 3, warfarin should not be used first, but after direct thrombin inhibitor is started. There is a clinical tip here that which states that do not transfuse platelets for patients with HIT because this may worsen the thrombosis. Let's discuss so-called phospholipid syndromes. There are two main syndromes, one is lupus anticoagulant and another is anti-cardiolipin antibodies. Both can cause thrombosis. Anti-cardiolipin antibodies are associated with multiple spontaneous abortion. APO syndromes are only cause for thrombophilia with abnormality in the PTT. The medication Funda, this is a clinical tip. The medication Fundaparinux is safe for HIT. The best initial tests are mixing studies. The most accurate test is Russell Viper venom test. And let's go to the last. We need to treat this patient with heparin and coumadin. APL syndrome we need to know that APL syndrome requires lifelong anticoagulant. Once again, dear listeners, thank you so much. This is Professor Nick, Triple Nick channel. Once again, this is PA Nick from Brooklyn, New York. If you have any questions or suggestions, please feel free to email me to my email, which is very simple. The email is nickm like Mary, D like dog, the number 1 @gmail.com. Have a good night.